Almost. Yeah. Good morning and welcome to our YOSI session 2, which is Controversies in Ophthalmology for YOS. So we have, for the panelists, we have Dr. Ashish Ahuja here. Dr. Ashish, if you can please join us. Dr. Gunjan Budhiraja is here. Dr. Gunjan, if you can come in. Come from the side. Do we have Dr. Ipsita Konar here? Yeah, please come in. Dr. Aarti and Dr. Devakant. They are yet to come. So anyways, we'll start with our presentations. And the first controversy we are going to talk about is ECC versus SICS. So it's a 4-minute talk for each, and please stick to the time so that we can conclude and we can have good discussions. So I think what we can do is per session, we'll have the comparisons, and then we can have another 2 to 3 minutes of discussion. So this is how we'll close per talk. So the first talk is ECCE by Dr. Aditi Ghosh Dastidar, and over to you, Dr. Aditi.
Thank you so much. So I'll be speaking on ECC, stepping stone for cataract training. So who all of us have done ECC in our PG? Many of us, yeah. So many of us have not. Why ECC? It is a tried and tested method. It is a window to the intraoperative surprises that we are going to do later on when we go to complicated cataract surgeries. We know how to modify, convert and salvage tube ECC during any complicated cataract surgery, even a clear corneal phaco situation. So ECC indeed is a savior in complex situation. Why in residency? Why a stepping stone? It is the introduction to the skill. It will have a good learning curve. It is a savior. It is the first key to your wound management, your first suture, your idea to the world of penetrating keratoplasty. It's almost 1/4 of a PK, right? And students of today are going to be the teachers of tomorrow. So ECC is very important. Of course, the prerequisite are they should know the theory, they should do a wet lab practice, tissue handling, knowledge about the suture material, the knot, and one stitch at a time. Because if you go and sit to suture the wound at the first time, you are not going to be able to do that. So ECC gives you an idea of the ideal wound management, the suturing technique, how to take a suture, how to change your astigmatism, and it is very important to see how to manage the IOP fluctuations during the surgery. If not, we need our basics to become a better surgeon of future. So it is very crucial to know the basics, then only go towards a complicated surgery. And what is not expected? Of course, unsupervised surgery, wrong patient selection, in complicated and high-risk patients. So the patient selection is very, very important, and not to combine a lot of surgeries in a same setting. Why even now? In surface cases, even now we are doing surgeries when we do not want to touch the sclera, conversion and salvaging in a very high-end clear corneal case. When you want to take out the nucleus, you can just extend your corneal wound. We should know how the PC flutters and our heart flutter during IOP. So the take-home message is it is a stepping stone for cataract surgery, and we cannot ignore it. Thank you so much.
Thank you, Dr. Aditi, and we'll call upon Dr. Menak. Let's see how he defends it.
Yeah, so good morning everyone. Thank you AIOC and YOSI for having me here. So I'll be talking about SICS, which is a stepping stone for the cataract surgery. So I'm not a very good candidate to speak about it as of now because I'm not doing too many SICS, but I'm really grateful that I've learned it during my residency because it comes handy in many of the complicated and tricky situations which you'll end up in. So as we know that in the evolution curve of the eye surgeries is also that we started off with ICCs, then the ECC, and then we went on to the scleral tunnel, the SICS surgery, phaco, and now the latest, the most advanced femtolaser assisted cataract surgery. The curve of evolution is actually very important. So if you go through the curve, then only you learn your basics very appropriately. The scleral tunnel, it was introduced in the 80s for better wound healing to reduce the SIA. So I'll just cover it in 3 topics. Why it's important for the residents to learn SICS. Why? For the practicing phaco surgeons, and there are certain additional learnings for the SICS. So SICS is actually has got a steep learning curve, and it is unlike phacoemulsification. There are multiple steps to it, and if you go wrong in any of the steps, then your surgery can get complicated, and you may not get the like the desired results. So for each and every step, you have to be very particular. For the residents, these are certain tips to master your SICS from the initial go. SICS, there are it's a very multifaceted surgery. There are multiple types of incisions, and each of them have their own advantages and disadvantages. There are multiple methods of nucleus delivery in SICS, and which you can try in different situations. And what it does for the beginners is that it gives you a feel of the tissue handling. You learn the biplanar and the triplanar tunnel construction. So it gives you the concept of making continuous rexes. It teaches the residents to deal with the complicated cataract surgeries, because usually these are the cases which are posted for them for ECC and SICS in the initial go. So if you're a phaco surgeon, you're doing your phaco very confidently, why do you still need to know the art of SICS? In certain complicated situations of corneal opacity, scar, adherent leukomas, in very rock hard cataracts with poorly dilating pupil, fibrotic capsules, those having pre-existing zonular weaknesses, and poor endothelial reserve, these are the situations when you should plan for a primary SICS. Secondly, in certain situations, you may be stuck up during your surgery and you may need to convert your phaco to SICS. There may be wound related problem, the CCC may run off, there may be an intra-op meiosis and poor visualization, and most of all there might be a PCR and you want to save off a nucleus drop and a grave situation. So in those cases you may convert it to the SICS and give a very fine result. So just see. So it's just a very small video of recently done SICS, which I did after pretty long time. So as you can see, it's a very intumescent and hard brown cataract. So the moment we started with the rexes, even after the aspiration of the milky cortex, the rexes had a runoff and there was an argentinal flag sign. So you ended up with this kind of a complication. So despite this, we could salvage, we could take out the nucleus, we put the foldable IOL in the bag and the rexus margin that we could, and we could give a good result for the surgeon. So the message is that it gives it is a relatively more forgiving surgery as compared to phacoemulsification. Also, some additional points are there. As a glaucoma surgeon, it gives you a feel for the conjunctival wound, conjunctival handling, the construction of a scleral flap, and also you can combine it with the SICS trab in the complex scenarios as in phacolytic and phacomorphic glaucomas. And it doesn't need any sophisticated instrumentation and can be done for the CAM surgeries also. So to wind it up, it's not a dying art. So beginners can get a feel of the tissue handling. It's a savior in difficult situation, can be combined with trabeculectomy, and no sophisticated instrumentation is required for it. Thank you.
Dr. Menak, and I think let's start with the discussion part of it. I'll start with Dr. Gunjan here. Your call and your discussion as to what would be the better surgical approach.
Okay, so during the early periods when people are starting with tissue handling, it is better to start with ECC for some people, but now people are directly moving to SICS because SICS gives you the tunnel making and it's a very good procedure so that they can, transition better into phacos. So I think everybody agrees to it. Then transitioning from SICS to phaco is a very good choice because it gives you a lot of, parachute effect that if you are not able to do phaco properly, then SICS may be the choice, or maybe you get a better tissue handling capsular rexus making, and if sometimes you are not able to do phaco in the back, sometimes get out the nucleus, so they are much more better tissue handling in that. ECC as a cornea surgeon, I would not say it's a bad choice because sometimes we do not have choice, so we have to do ECC for some patients, but I have not done ECCs much. I would have done SICS in few of the cornea patients because now I have learned SICS to that level that I can manage them. But of course in the trainee, it's a good choice to start with SICS on Goat's Eye because it gives a very good learning curve for everyone, and you have numbers, especially in charitable institutions. There are so many charitable institutions who have a lot of bulk cataract cases as well. So that's easier, and it's a very fast process for them. Yeah. So anybody else can have a discussion on it.
Yep. Dr. Ipsita, your call on it.
I have personally not done ECC, but when I think about both the procedures, I've done SICS, but when we move on to other surgeries, I feel it is probably better if we would have done both in our residency, because both have some things which we take forward. Probably if we have to choose, once we do phaco, if we still have in certain scenarios, if we have to choose one of these as an option for cataract, then that probably will be SICS. But things like suturing, when you start doing a glaucoma surgery and you're coming across that as the first time, I think it would have been good if I had done ECC and learnt it then rather than learning it while doing a glaucoma surgery. So probably like how our seniors used to do that, ECC, then SICS, even if for a small while, and then stepping into phaco, that would probably make it a smoother run. That's how I feel about it.
We have Dr. Aarti here. We had a discussion about ECC and SICS. Your call on it. I think one thing which needs to be discussed is like our seniors, they used to do a lot of ECCs, and from our residency, we are actually subjected to SICS because like initially, I mean, I have done initial fight, and like we start with ECC, but that suturing becomes another difficult thing for us. And the initial days when we are actually struggling to start with doing an SICS, I mean, any of the intraocular surgeries, the hand-eye coordination is not that much. So learning that making a flap becomes slightly better as compared to suturing. This is what my take is. I think I'll ask Dr. Aarti and then we'll close it.
So sorry for being late. I was just in another session. So since I have not heard the talks, my opinion is going to be unbiased. I feel that it is good to have ECC training before having SICS, because I just heard you people talking about sutures. So taking sutures in ECC will help you in future as well. So if in case you want to become a corneal surgeon, you want to take a cornea fellowship, definitely you'll have some idea that how it is done. You will actually know whether I should do cornea or not, because I don't like suturing cornea, so I may not opt for cornea. And if in case you want to, even if you are doing phaco, you want to convert something, you will definitely need suturing. So ECC is something which you should definitely know. So I have done my DNB from South, and I have done 150 ECC before doing SICS, and I feel that that has actually helped me. And something which is there's no harm in learning. You may or may not use that, right? And were we discussing also phaco? No. So SICS definitely plays a big role. SICS is a surgery which each one of us should know, whether you are oculoplasty or a retina. I'll tell why. I visit to Africa for community work, and absolutely there is no option of doing phacoemulsification, and SICS was what everybody talks. So SICS is something which is not replaceable, I feel.
So the crux is we do need to know both the type of surgeries, and they are the stepping stones for cataract training. Thank you, Dr. Menak. I think we don't have Dr. Amit and Dr. Bhavini here. So we'll take up the third topic, which is buying diagnostics and OPD equipments, whether to use it buy fresh ones or refurbished. We have first Dr. Madan Gopalan, VG. He'll be speaking about fresh equipments to be bought, whether it is diagnostic or OPDs. Over to you, Dr. Madan Gopal.
Thank you, YOSI and AIOS for having me here. Now, I've been asked to say that, new instruments are better when you're going for equipment purchase. Well, that's a no-brainer, I would say. New equipments definitely work better. But, I'll try to speak about this in a different tangent. Slides are not moving. Yeah. So yes, I'm aware that this is a Yo Pavilion, young ophthalmologists, and our pockets are not deep, money is not in abundance, fiscal prudence is the key, all that is there. But as beginners, we have no equipment, and so we have no patience. We have no patience, and so we are not confident enough to buy new equipment. And this cycle has to be broken somewhere. In doing so, you need a cautious approach. You need to understand your own risk appetite, have a grip on the financial realities that you and your family may be facing, and most importantly, one should understand the language of money. There are a few special considerations. Apart from the tangibles, there are a lot of intangibles in owning an equipment, like peace of mind. Apart from direct return, there is the indirect return, the comfort, the feel good factor that you have is also important. Many of us may be in specialty practice where the second hand equipment may not be easy to come by, and then you would require a combination of equipment for a particular outcome. Let's say you require a microscope and a biome to perform VR surgeries. Are you sure that you can go for second hand equipment and make them compatible with each other? So what exactly do you want? Every young entrepreneur has to take this decision. Does he want fresh new ones, or would he go for second hand or pre-used ones? I refrain from using the word refurbished for now. I'll tell you why in a bit. Now I'm presented with these two vehicles. Now which is the new one and which has already done 1 lakh kilometers? I have absolutely no idea. And why is that? I'm not the technical expert here. I have not been trained in this domain. I do not know whether this machine is good or not. I do not know how to read machines. Well, I can do that. I can actually, spend a considerable amount of time understanding machines, learning about them, reading up, visiting places and all. But we are at the prime of our lives, and any activity or any work that is out of my core area of competence is definitely not worth it. So return on investment is always profit over the cost of investment. Profit is revenue minus expenses, and any equipment that you buy has to be contributing to your revenue. It cannot be a liability contributing towards more expenses. Now if you're going to get a second hand equipment, it stands to reason that somebody is selling it. Now why is that someone selling it? Often you'll find on proper analysis that these are one of the causes. Through poor function, unmatched expectations, it's an outdated version, he's having frequent breakdowns and high maintenance. The only one good reason probably a buyer could get a machine is that somebody's bought a new machine and he's winding up his practice for whatever reason. So how often is that going to happen? And then this is not often spoken about, end of life or longevity of machines. No matter how well a machine is maintained, there is only this much duration of time that it can work on. So when you are going for a second hand machine, you are going to get it somewhere in the middle. So in which part of this inevitable downward slope are you going to get your hands on the machine? You have no idea of actually knowing. And yes, refurbished, I've refrained from using the word refurbished simply because in order to truly call a machine refurbished, it should have gone through all these processes, and proper trained personnel should have done this. Now how often can we be sure that the machine that you want to buy has gone through all these processes? And do we even know who the seller is? Do we have any idea about the authenticity of the person you're getting it from? No, we do not know all this. So that, my dear friends, is why I prefer new equipment always. As beginners, on every day's practice, you have 1,000 things to worry about, and whether your machines would be working well or not is not something that you'd be worried about on a particular day. So new ones are always better. Thank you for the opportunity.
That was very interesting, Dr. Madan. We'll have Dr. Ankit Agrawal speaking about refurbished equipments, and then we'll see how to go about, but nicely done.
So, good morning everybody. So I'll be talking about refurbished equipments. So we all heard Dr. Madan speak very brief, in a very clear way, why we should buy new. But a point which he raised, which I will raise again, do we all have so much money? See a basic setup, just a slit lamp, a chair unit, OCT machine, because now OCT is a part of basic setup, a microscope, a phaco machine, that's it, right? If you buy new, it's going to cost north of 1 CR. Do we have that much money? That's why we buy refurbished. Not necessary that we have to buy refurbished which is so old that it's outdated. There are many centers who change their machines every 5-6 years. 5 years old is not really outdated. Ophthalmology is really inexpensive affair. We cannot rely on everything new because the charges are increasing day by day, and with certain government schemes, the price of treating a patient is reducing it again and again. So in the beginning of our careers, when we don't have so many patients, we have to attract patients by the equipment which we have. No, we did not tell the patient these are refurbished equipments. The patient equipment should work. It should help us in our practice. We should be able to diagnose. That's the main point of it. Everything is connected to our finances. We have high rents. We have high overheads. A new equipment comes with various other liabilities. We might have to do IOL bundlings with them. Then we are forced to put a particular IOL for next 5-6 years of our life. We might have to invest in various compatible softwares for the new equipments. And when buying a new equipment, we might have to take loans. The interest rates, then again we have to start paying money for that. So, how we go about it? Buy refurbished, but be very strategic about it. Don't buy an equipment which is too old. See what I do? See, I bought an OCT recently, a refurbished one, but I didn't go for a time domain one because it's outdated. We know it's outdated. Go for a spectral domain OCT which is currently being serviced. That is very important. The company should be currently servicing that particular machine. That we can definitely ask the company person that will you be able to give CMC or AMC for that. That we can picture and that we can decide. We have to market these machines to our patient that we have this particular machine. See, a new say multi-spot laser might be costing something around 30-35 lakhs rupees, but in our refurbished one will cost something around 10-15 lakh rupees. So we can market. So we have a Pascal laser with us. Patients get impressed by armamentarium. Maintain a lot of machines in your OPD. Patients think, oh, you are a good doctor. There is a faster growth in revenues and volumes because if the more machines you have, the better tests you can do. You can charge them. You can get more money from them. Now, we have to decide whether a machine is refurbished is worth buying. Check the equipment properly. Spend some time with it. We are in the beginning of our career. We are not so busy that we cannot actually research an equipment. Spend some time. We all are very tech savvy. We can research on internet. We can talk to our friends who are in various institutions how they are handling these. We have to find out whether they are the current generation or are the previous generation or how old. We have to think about the pricing. Just don't go by the fact that this is 10 lakh rupees. We have to find out what was the pricing when it was originally bought. Will it be viable in today's scenario? We have to check the condition of the machine personally. I always go to the place where it is stored. I see it there, then I get it packed in front of me and then I buy it. We have to know the authenticity of the seller and the durability of the machine. Thank you.
Thank you, Dr. Ankit. That was very nicely presented. So I'll just ask both of you like one question. If you want to buy a cataract machine, okay, a machine for phaco, right? So would you, as you're saying, would you go for a newer machine or would you want to go for a refurbished one? And what would be your pros and cons? Because what Dr. Ankit was talking about is you should know about the machine, I mean, whether it is working and whether it is equipped with the latest. Because since phaco is something which everyone is doing, and we'll ask our specialist, the panelist after that. But for a basic person, when somebody is stepping out, one criteria is like there are some whether to actually go for newer machines or whether to go for refurbished, because your clinical skills are also in take. So even that comes into picture where if you're buying a machine to do surgeries or if you're seeing an OCT machine, so even that is something where a person who's a retina specialist, he will be able to pick up some things. But for a general comprehensive person, it's a very different take for him. So can you just give me those, then I'll come back to it.
Yeah, so besides the debate, to be very honest, what many points that he said are true. And to answer the question that's put in front of me, in fact, I have a refurbished vitrectomy machine. And why did I buy that? The single point was it was sold to me by the hospital where I was visiting. So it was just down the road and I used to do all the retina surgeries. I was working on that particular machine for 3-4 years. And then they said, why not you take the machine itself? We'll send our cases to you. That was a good deal, win-win situation for both of us. So the crux of the whole point is I have worked with that machine. I have not gone and seen it somewhere in a conference, in a stall or something. So I have worked with that machine. I know what it's going to give me. Point number one. And point number two, I'd be a little more comfortable going for a refurbished equipment with mechanical parts rather than a refurbished equipment with electronic parts, if you get the drift.
Dr. Ankit?
Yeah. So we are in the exactly same scenario. I have an Alcon Constellation, which is a refurbished machine. So before I bought that, I talked to my Alcon engineer whether you will be giving me a CMC for that. That machine had a lot of issues, but because he was ready to give CMC, in last 1 year he has replaced almost every part of that machine, and it's working like new now. So that's what the company should be able to support you. If you get a CMC, after that you are home free, because now the CMC is there. Anything goes wrong, it is covered. That's what I never buy a machine which is not being supported by the company. That's the one rule I follow. And microscopes are the best examples for that. See, microscopes have all mechanical, but as you said, all mechanical. Only the electronic portion is the light source. Okay. So I buy microscopes. We have 3 refurbished microscopes, and all are working very well because example, Zeiss has a lot of ex-engineers working around, freelancing, doing repair works, and it's getting by very easily.
So I would want to ask Dr. Ashish about this now, since you're working in a one-tier place in Mumbai. So if you have a refurbished any instrument, or maybe people do go in and they do check out with what sort of instruments you have, and then only they would want to get operated at times. So what is your take on it, where you say that this is the machine which I have, and another ophthalmologist down the road has a better machine to operate? So how would you cater it, and what is your call, whether would you want to take a newer machine for that?
So see, we are in a very price sensitive market. If we see India overall, patients will not come and ask us, what microscope or vitrectomy or this you are using. They will see the basic end cost of a surgery. They see the confidence of the doctor, what percentage or guarantee they are giving as to the improvement will happen post surgery. See, when we are beginning our journey, we have option of Indian versus an MNC. Buying machines of Indian companies which will cost between 30 to 50% of what MNCs are offering. And like if we take Alcon Constellation, now issue is they are giving everything in packs of 6. So we have to buy everything in packs of 6. And if we see the macro trend, what is happening all over India with cashless everywhere being promoted, the payments will come after 2 months. You're buying everything in packs of 6. Dealers are giving 30 days payment period, so heavy cash flows are getting affected. Insurance companies are paying 20,000, 25,000 packages for the surgery. Vitrectomies are 35, 40,000. It is not practical to offer that with the MNC machines. We have to adjust ourselves on the Indian ones, and see with AMCs and CMCs also on the Alcons and other machines goes to 3 to 5 lakh per year. So if we train ourselves on Indian machines, but yes, I feel certain things like a phaco machine, that is our bread and butter, we should not compromise. But on other things, yes, we can buy other machines, like Earthly is the best selling machine. So based on demand and supply also, we see that almost 20% the prices are increasing year on year. Even optical biometers, if you see, Tommy OA2000, so from Japan, even Nidec is from Japan. Nidec is at 15-16 lakhs since 6-7 years. Tommy has increased to about 20% year on year. So a lot of, it's a demand and supply market. And just to stretch what you said, buying equipments which have more mechanical parts, yes, I agree. So auto-ref, slit lamp or a microscope will be a good buy to buy second-hand ones. I work in a group family practice with my father, and we have auto-ref which is working since 14-15 years. Microscope is a safe buy. So I recently bought one Apasami True Glow higher-end microscope from sir recently. So I'm quite happy with that. So we have to be very price sensitive in India. Maybe we'll discuss further also. We have examples across sectors. If we see Indigo Airlines, they work on very cost effective lower pricing model where they have split buying tickets, seat preferences or fast forward or buying meals. So they have separated that from purchase of the seat, and they've become 60% market shareholders. We'll discuss more later.
Yeah, so I would want to ask Dr. Gunjan, since she is a refractive surgeon here, so how would you go about with the idea of buying newer machines? And I would actually also want to emphasize on something where you can have group practice, where you can not have the onus of buying everything onto yourself. So if you have 2-3 people, so somebody can sponsor, and like in a group practice, there is a possibility that someone can go ahead with buying newer machines depending upon the demand of the place you're working.
So, as everybody pointed out, like if you are having a anterior segment practice, a cataract refractive practice, in cataract part, I would not like to compromise with the biometry machines, and also I would not like to compromise with the measurements that we do. So for that part, I would definitely want to buy a new machine. But then in the LASIK etc. machines, if you want to buy, they are white elephant, so you cannot buy alone. You always have to either bundle, or you have to find some group partners to start up a machine. Sometimes a good buy if you are having a refurbished LASIK machines. But yes, refractive practice, if you specifically ask, refractive is more of about branding and advertising, and also patients are aware which machines you are operating them on. So in a metropolitan city, if you're practicing, then patients are much more aware about what kind of machines you're using in the refractive. In the cataract part, they do not ask you which machines you are holding up, because they are like more of lens or IOL oriented, and insurance companies are paying for IOL. So phaco machines maybe we can compromise with, but with the microscopes, refurbished, they do work better. If you're buying from the company, they give you good schemes, like Dr. Ankit also mentioned. So if those kind of things are happening, why not buy a refurbished? But few things you will have to be very careful when you are branding your place. You can always buy that kind of machine with group practices. That I feel about. Baki, Dr. Aarti can also shed a light.
So I feel it depends on your usage. So something which you are going to use for every patient, you want to buy the best one. So let's say I'm seeing 50 patients in OPD. So I don't want to have a second-hand slit lamp or NCT or auto ref, because all of my patients and their relatives are going to see that, and I'm going to use that more. So I'll try to buy that a new one. Something which I may not use that often, let's say for that matter, a perimetry. So I may do 10 perimetry or 5 perimetry in a day. So I might compromise on that. So it depends on the usage. Here we are talking about, the topic says that diagnostics and OPD tools. So yes, we can compromise on getting a second-hand microscope or refurbished microscope. But you may not want to compromise on a phaco machine, because that is going to be your bread and butter. And if in case you're stuck during the surgery, that might be a trouble for you. So it entirely depends on your usage. That's how you can prioritize which one to buy fresh and which one to buy refurbished. But both of them definitely have a role in your practice, whether you are youngster or not.
So Dr. Ipshita, your take on this, and then we'll close.
So, just like we are discussing, I feel that there is no straight either this or that. It depends on what it is, from whom you're buying, how well you know the vendor, even if it's refurbished. And at the end of the day, we buy refurbished because of the monetary factor. And if like for the instruments which we are using, for like you were telling, that for all patients which are more commonly used, and we can get loans which are where we don't pay the EMI for the first year, or which have no early repayment penalties, and if we can get those deals, at least for the instruments which are most commonly used, we could choose the newer ones, and for the others the refurbished probably.
So yes, the general consensus is what Dr. Ipshita is talking about. We should set our goals, and depending upon what the availability and how you want to invest into that particular machine and how much return that would give. Because the ROI is one thing, where some machines are bought for the ROI and some machines are bought depending upon the scenario where you are placed, and where you don't look into the ROI. It's more about the marketing and getting patients to your OPDs and seeing to it that the amount of your flow becomes much easier, where the patient has more like friendly sort of an experience when they come to your hospitals. So thank you, Dr. Madan and Dr. Ankit. We'll move on to the next topic, which is administrative part of private practice, and we would want to call upon Dr. Tushar Grover. He'll be talking about formal training to be required for training bar MBA. Whether does it make it easy? Over to you, Dr. Tushar.
So thank you. My gratitude to YOSI for having me here. Once I have the slide, okay. So I'll be talking in favor of formal training or an MBA and why that makes it easy. So I'll be talking about why formal training is important and why learning on the job may not be just enough. So starting out with formal training. So essentially, we started talking about eye care as an industry only recently. We hear about mergers, acquisitions all the time. There are newer challenges coming in. Standardization of rates is being talked about. So, we've done more than 10 years of medical education now, but nobody ever taught us how to deal with any of these challenges. Which is why formal training in administration or business gives you that. It gives you a basic understanding of how finances works, how operations works, strategy in terms of business. All of these things are important to have a good baseline knowledge of before you start implementing anything. I have done my fellowship from Narayana, I've done my post-graduation from Arvind, but when I was doing the course, I was able to visit these places and look at it from a completely different perspective. When you're studying there or working there, you never even notice those things. You never know how they overcame those struggles or how they managed those volumes or how they grew. It's just something that you never think of, and the only way to do it is to really do an organized course and therefore get a better understanding of how these things work. You also, when you do a formal course, you really get better at managing people. You organize events, you organize seminars. There are formal courses on training with people management, and this is something that really helps you in the long run. Also, the people that you're doing the course with are all people in different branches, different fields, doing extremely well in their respective fields, and they're a great network to have. So even now, when I have challenges, when I have difficulties, I call one of them who's in an area which I know would be related to my challenge, and I get great answers from them, something which I would never get from my doctor friends or my ophthalmologist friends. Also, you learn problem solving skills in an organized way. You read all these case studies, such as these Harvard case studies on various organizations that were facing challenges very similar to what we might be facing in life. I mean, whether you want to scale up a hospital or you have other operational challenges that you're facing, you read these case studies, you see how those people managed, how those organizations overcame those challenges and were able to get over it. So that also really helps you. Again, very important is that when you're taking administrative decisions, you need to take the decisions as an administrator, not a clinician. And having organized training gives you that ability to dissociate the clinician in you from the administrator, so that when you're taking those kinds of decisions, it's not the clinician in you that is taking that decision. So talking about why learning on the job may not be enough. When you're learning on the job, essentially you know only one way of doing things, the way that you do things or the way that things have been happening in the organization before that, and you tend to have a very myopic view of how to manage. There are bound to be inefficiencies and wastage of resources because you don't have formal training in these things, in operations, in all of these areas. So there are, at least to begin with, as you start, there are going to be inefficiencies. Understanding financial statements can be very challenging, even to those who've read financial statements many times or who've been trained in it. So, when you get something from your CA, you should be able to question it. You should be able to see what is wrong, what is not written correctly. All of these things are extremely important, and you will learn on the job, but it will take you many years and you'll make many mistakes before you do that. When you're buying equipment, etc., you all must be knowing there are these 4 or 5 company MBAs who are going to come sit with you, negotiate with you. You need to have a good basic knowledge of how negotiation works, how finances works, to be able to take the right decisions. You might learn on the job, but you'll make many wrong decisions before you take the right ones. Again, HR and staff management is very challenging in any organization. So if you have formal training on how the policies work, how different sectors have HR policies, you're able to set in a groundwork much better for your organization. So to summarize, I mean, we've spent a decade in learning ophthalmology. I think spending a year or so to learn practice management, to learn administration in business is probably the best investment that we can do. Thank you.
Thank you, Dr. Tushar. If you can wait here, we'll ask Dr. Anujit Paul to come in and let's see what is his perspective about administration and private practice without any formal training.
So thank you very much, sir, and thank you to Tushar, sir. I do agree with some of your points. So, but as the topic reads, no course required, and in which cases you should not go for an MBA is more important than in cases that you should go for an MBA. So just to describe to water down the course, not to reduce its ability to educate people. It's more of a theoretical and a practical training in business and in investment management. That is the primary goal of an MBA. But over here, the backbone of contention is an MBA absolutely redundant for a healthcare professional, or is it partially redundant, or can we even consider it going forward? Because we only hear the success stories. We do not hear the vast majority of people who also have that MBA degree with their MBBS or MS degree. So what we learn is application is more important than information, and business management is one part of it, but learning to apply it is a life skill. So does anyone remember all their life skills from their childhood? Remember getting your first bike and not having to read a manual or attend a course and just learning it on the fly? Remember falling into the pool and your younger or elder sister or brother pushing you and teaching you that life skill? Yes, that's how you learned it. I mean, today's kids or my children in the future might watch a YouTube video or attend a course on it, but ultimately they will have to jump in the pool to learn it. So there are pros and cons. I'm not here to deter anyone from doing an MBA. It's just to open your mindset about when or why you should do an MBA. It does give you global exposure. It does increase your brand value. It does give you an entrepreneurial support. And definitely it is very important for networking. Stuck in MBBS, stuck in MD or MS, stuck in DNB, we have lost contact with the outside world. This MBA does take us to the outside world. But let's look at one more small example. Today's laparoscopic surgeon, did he learn laparoscopy during his residency? Did he learn any of these ports and maneuvers? No, he did not. He learned it on the fly. He did learn the basics, and the basics are available everywhere. He learned open cholecystectomy during his residency, but today he's teaching it in a course, but he never learned that in a course. So a few days ago, a resident of mine was telling me that he or she wants to learn gonioscopy. So not to deter anyone from SSTC and TSTC, but he or she wants to learn gonioscopy in SSTC or TSTC. So you can do a course on it, but as anyone who's held a gonioscope and is a glaucoma practitioner will tell you, if you do 100 gonioscopies, you're well off, and if you do 1,000 gonioscopies, you're even well off. No amount of diagrams will help you over there. So once again, coming to the fact that I'm trying to reiterate that applying this is a life skill. So the entire gamut of being a doctor as well as managing a business administration includes man management, people management, growth targeting, growth assessment, most importantly liability assessment, and finally taking all that into account, revenue generation. So coming back to the cons of an MBA, so I was sitting with my MBA friend who's earning 3 times the amount I am earning today, and he was telling me that to do an MBA, you need to have around 28 to 30 lakhs in your pocket. That's for the top B-tier schools in India, and there are about 400 to 500 seats for the same. So I don't want to deter anyone from a bottleneck, but imagine you must assess whether you're ready to invest that amount and what are the returns you get from that amount. Full well knowing that it is not a technical skill. It is not like MIGS. You attend a couple of courses, you do your first MIGS, your first eye stent falls onto the iris and you pick it up and someone tells you this is what you do. You have to cater it and tailor it to every individual, to the company that's coming and trying to break a deal with you, to the staff who's trying to be naughty or not trying to listen to what you're trying to say. So it will not teach you anything in practice management, but you will learn it on the fly. Once again, it's not a golden ticket for everyone. Know your strengths, know your weaknesses. An MBA is good, but knowing when you do not require a course is even better. Thank you.
Thank you, Dr. Anujit. That was very interesting. We'll come back to Dr. Tusharya. I'll ask Dr. Ashish to give his pointers, and we'll have more discussions on this.
So yes, see, I feel there are about 6,000 plus individual eye care practitioners across India who have their own clinics. And when we are opening our own hospital, it's like a startup where we have to manage and do everything ground up. To managing of staff, to accounts, marketing, improving on our skills. And there are a lot of things, which we have to learn, managing finances, which we are not taught in our postgraduate days or even schools. So, but again, finding out time for a structured course is quite difficult, I feel. It's good that, you have managed and you have done it. And even AIOS at its level has a program called Leadership Development Program, where they teach a lot of administrative skills and leadership skills to individual ophthalmologists. And I feel that, see, we have access to a lot of books which we can read, and if we read about 1 hour per day of books on different aspects, we could be in the top 10% of our field very soon. So I would recommend one book called The Personal MBA by Josh Kaufman. That's a very good book on learning the basics of MBA. There's another book on Art of Negotiation, that's by an FBI agent. There is another good book on financial planning for life. So if you see an average CEO of a corporate, they read between 30 to 50 books per year. So if we have that habit of, reading books which are easily available, we can get a lot of information, and then we can modify it and apply it in our field.
I'd just like to clarify
please,
one point.
please.
So, I think I completely agree with you about doing a generic MBA where, you go do a resident program for 2 years. It's not practical for us, and I don't recommend that either. Just that there are a lot of working MBAs for working professionals, and there are specialized MBAs which are directed towards healthcare. And I also don't recommend doing a long 2-year MBA either. I'd recommend doing like a general management course, which is maybe a year long, where you have to spend some time in the business school, but the rest can be done online. So there are a lot of modifications available. So, just like how we do Cornea Fellowship, Retina Fellowship.
Exactly.
So we don't have to do a comprehensive business fellowship. We have to do some things which are relevant to us, find a relevant program, find something where we can devote the kind of time that we have available and do that. Definitely, I don't recommend doing a 2-year resident MBA either.
A couple of things, Dr. Tushar. Can you tell us what course did you do and how did you go about, and what would be the ideal time to actually do these courses?
Yeah.
Because once you start getting into your practice, it becomes very difficult to even find holidays, let alone doing a course like that. So what drives you to actually do that?
Yeah.
And when do you actually should do, like as we do your fellowships as early as possible?
True. So what I did was a general management course from IIM Bangalore. This was essentially a 15-month course, out of which 40 days I had to be in IIM. And the rest was online, and you get a lot of study material through their application, etc., on their mails, and you have to read up all of that and go to the. So it's a great exposure to have, and it was not. It's not about a general management course. It's about understanding the global scenario in terms of healthcare. It's not going internal, looking at inventory, etc. So I do believe that it gave me a lot of knowledge, in how the world works, in how finances works, or how businesses work, and I think that has really helped me. The right time to do it is as soon as possible. I did it right after my fellowship finished. I was in practice, just starting out practice, and I thought that was the best time, because once you get busy with practice, it's very difficult.
Yeah. One more question: what was the toughest decision you took as a CEO rather than the CMD? Maybe not a medical director, but the in charge of your place.
I think the toughest.
How was it different?
I think the toughest, I won't say it's one decision, but the toughest thing I find is managing people. And again, I spent most of my life, grown-up life at least in South India, and the transition to Delhi itself was a huge change for me. The staff there, the patients there, to set systems that work in terms of HR, in terms of leave, in terms of timings, it is very, very difficult. And I think setting up that structure and that systems is the biggest challenge, which I still have to deal with.
Absolutely. Like, there is no course for man management.
But you know how, you know what is the right way to do it, and then you can modify
absolutely.
it. So you have a baseline.
Absolutely. Like, not all cataract surgeons have done an IOL fellowship, but those who have, some people have learned anterior vitrectomy along with other techniques outside. So it does work. It does work.
True.
Can you elaborate any smaller courses where people can actually take in, and not what Dr. Anujit was talking about, 30 lakhs or if there are free courses, because a lot of newer courses on AI management and depending upon imaging, like this is what is happening with us, where they are giving online courses, and it does help you with your CV as well. But then again, if you can recommend a couple.
So in terms of online learning, there are multiple websites now. For example, for hospital administration, there are things on MedVarsity. Udemy has a lot of courses if you're interested in artificial intelligence or just understanding financial statements. Coursera has courses. There are a lot of these websites that are available. I wouldn't say they're free, but they're quite reasonable. And that's something you can do. It's not going to help you get a job or something if you want to transition from a clinical to a non-clinical role. But to apply it into the non-clinical areas of your work, it is quite useful.
We have someone from the audience, if you can come in and talk.
Hello. I am Dr. Mahesh Somani. I have done 34 years of practice now in Indore, and at 2001, I made a group practice of 7 ophthalmologists together working. But I have done my MBA as a regular student, selected by CET from DAV Indore at the age of 55, and cleared with 8.24 as a regular student because classrooms were in the afternoons. I have done complete work with.
Excellent.
And applying it, I modified one more line with me. Now I am going NMH consulting also. So in life, learning is never ends. You can do when you want. Doing MBA is always good, and regular courses cost less also. It is not necessary to go for 30 lakhs. I paid only, I think, 2.5 lakhs for the classrooms. Okay. So, but overall, one thing is there for mail management. It is the communication skill. This is important. What is said is never important. How it is said is always important. So that makes learning, and a good administrator is who can listen the things very nicely, not to answer and react immediately for any man to manage. So that's my personal experience. Okay, thank you.
Thank you, sir.
Thank you so much, sir. And I would want to close this topic, and we are overshooting somehow. So we'll take the last topic for the day. We have, I would really want to thank Dr. Anujit and Dr. Tushar for their insights. And I will want to call upon the next speakers. I want to call Dr. Vedang Shah for talking upon financing your private practice equity.
Good afternoon, everyone. Thank you for the opportunity. So as youngsters, I think it is very important to understand and know how we are going to move about our finances. And this is something that we need to understand very closely. So before we take that decision, we need to understand a couple of things, and that is knowing the right amount of finances and the resources at the right time. And post-pandemic lending, getting debts, getting funds, all these have become a challenge. So to understand what kind of finance we are looking into and what kind of resource we want, it is important to identify these steps of growth that we aim for, to identify the milestones that we would like to achieve in particular set of time, and also have an excellent support system for that. So as an entrepreneur, it is important to know how your personal resources and personal standings and savings are, to identify and understand the difference as to what is your short-term goal and what is your long-term goal. And then maybe depending on that, may understand whether it is a part of a normal operation that you are looking into and finance it accordingly, or whether you want looking into a long-term goal and accordingly you need to have a debt collection or something like that. So coming to the types of financing, there are basically two: equity and debt, and there are other sources now because of lot of angel investors and lot of fundings that we are having across the overseas also. There are various other types of finances. So let us look into the pros and cons of each of them. So equity is also sometimes called the risk capital, and it involves your 100% finance. The other option is where you dilute your shareholding, and instead of giving 100%, you can have it along with your some investors who may be medical, who may be non-medical, and then move forward accordingly. But having a self-finance, which is basically a proprietorship, you have the complete ownership, you have the willingness and the ability to take risks, so there's no headache of repaying the loans. You are not time pressed for payments. You have availability of short terms and quick funds. So for example, a machine gets wrong somewhere, or there's some immediate need of something, you are not self-pressed or to get loans and debts. And at the end of it, maybe when you are at the fag end of your career, even if you want to exit, you can exit with the profit. So the other important thing is you can invest whatever profits you are earning from your business into the business accordingly, and so that facility or that part of it is within your capacity. However, there are some cons, and most importantly the risk. So if you don't have the ability to take that risk, if you're not able to fund it, definitely you should go for debts. There are other options, there are other cons like mortgage, their personal assets. There is no direct tax advantage which is there in case of debt, and definitely you'll have to keep a separate contingency fund, as no one can predict the future. We have all experienced the COVID times, and this is one of the highlights of that. So coming to the angel investing or partnerships, it is basically a private non-professional investor. It may be a friend or a business associate. Important is to identify a formal MOU or understanding, so that there are no legal litigations or anything. And angel investors, the side to this, the pros are basically there are less risk, less management. You can concentrate more on your work. You can take advantage of the investor's experience on the workplace, have increased networking, and also get follow-up fundings if required. However, you lose the ownership, you lose the decision making. Very, very difficult in this scenario to find like-minded partners or like-minded investors. So the risks of litigations increase. So looking into the sources of capital equity, there can be seed funds, business angels, venture funds, corporate funds, and of course stock markets. Last but not the least, let me just have a brief into the cons of the debt investing before my friend here speaks about the debt. So the debt basically involves low willingness to take risk. There is no ownership involved. There is a lot of influence of the contributors. You are always time pressed to pay the interest and the loans. The bank usually obtains or asks for an yearly report or obtains the financial reports. So you are absolutely clear, and you have to be clear and open about it. And business owners must sign a promissory note. And as the scenario is changing every year, there are varying interest rates. So these are a couple of cons as if you're looking into a debt investment. Thank you.
Yeah, without wasting any of the time, we can ask Dr. Ashwini to put his defense.
Let's go to the my talk, the financing your private practice by debt part. So before going to debt part, the mindset is more important. Before you start your own setup, to overcome the fear of losing, fear of going bankrupt, fear of not able to run your clinic, fear of competition. So once you overcome, then comes the debt part or equity part. So there is no growth in the comfort zone, there is no comfort in the growth zone. So mark my word, nothing will happen. Your center will make you earn from the day one. Once you decided to open your center, you need money. So that is from your own saving or parental inherited or debt or loan, or as a doctor said, to dilute your liquidity, or start slow and grow with increase in your revenue, or your well-wishers or friends, seniors give you loan without any interest. So debt, a burden or boon. So depending on your caliber to grow your business. So if you look at data, HDFC Bank has 58 lakh crore of loan. Reliance has 31 lakh crore loans. So these companies are biggest companies in India, still they have loan, so much loan. So loan debt are not bad if used properly. In fact, government gives loans to doctor in less interest. I will defer post-COVID, the loans are become easier because government set target to increase, gives target to banks to give loans at lower cost to the doctors. And there are different schemes by different governments where government support organization by giving some money to the healthcare because they are generating the employment. So during my when I want to opening this my center, there is Arogyam scheme by SBI which they are providing 7.95 interest for doctors. And in Himachal, one of the senior open center, they give 25% of capital subsidy. If you invest 1 crore, they will deposit that amount. After 2 to 3 years, you can remove that money from your account. So every state have their own rule. You have to look for that. So there is whether it's a good loan or bad loan, there is a talk on this in our instruction course in the same hall at 4 o'clock. So the advantage is you can start with the bank if you take a loan and take all type of machines so that you don't have to refer to patient to another center. Patient will have confidence to get all treatment under one roof. You can do marketing, you can do invest in interior. First impression is the last impression. You can hire marketing person because you have money in your hand. So basically money is there, so footfall will start increase from the beginning. The disadvantage is you pay for more to the bank, you will under stress if you don't meet your EMI. Ultimately it's business, and like every business there will be good days or bad days. Don't take excessive loan so that you feel burden. If something happens, just like I broke my ankle after I start my clinic. So taking a loan at that time becomes my headache. So there are disadvantages are there still, but it overcomes the benefits. So if there is a risk, so it is worth taking. So there is a risk everything that isn't. So how to overcome the disadvantages? Start with a group of doctors, share the loan, have backup plan. You should have at least 6 months of survival money with you. And that from friends and families, best option, they don't take interest. I got almost 25 to 30 lakhs from my friends without any question for I have to pay within next 3 years. Although I'm debt free now. All thanks to them, they invested in me, so trust on me. So there is no burden of EMI in these scenarios. So my take, don't ever hesitate to take loans to build your expand business. Don't take a loan to buy land and to build the building and then interior because it takes time. So that during that time you have to pay the interest. So you won't be earning during that period. Best is if somebody investors gives money to you as a loan without interest. You need to be lucky. I think I'm very fortunate. So my take is to take a loan to expand. I'm thinking to take a loan when I want to expand. So thank you.
Yeah, Dr. Ashwini, thank you so much. I would want Dr. Ashish's pointers on this.
So yes, this is an important question on how to grow and expand your practice, but it should basically start with a very simple question as to what we want from a 30-35 year career, as to how much amount we want to put in practice and save. If you want to invest 30,000 or 50,000 per month for your future, for your family or for your retirement fund, and how much risk you want to take, the remaining you can either go for a loan or self-funded. Certain options where you can lower the loan interest is loan against property. If you have a house or a commercial place, you can give that as a collateral. Gold loans are cheaper at about 9% interest. That is a good option. And as we are starting, yes, we should start slow and then gradually add more and more equipments into our practice. Also, we can negotiate monthly payments from dealers. They usually give us 12 to 14 months or even 24 months of EMI options on equipments which are more expensive. Part bundling on IOLs is also a good option, but it should be comfortable and we should not be forced to do more than maybe 30% of our lens usage per month into the bundling. That would be a comfortable buy. Again, buying Indian equipments from Indian companies would be a good option to start than starting with MNCs. See, patients usually want results. They want lower cost of testing. Ultimately, the cost of the equipment will be borne by the patients only. In Mumbai, I have doctors, who charge even 9,000, 10,000 rupees for an OCT scan because they have an Heidelberg machine. So we have to, rationalize what we are, spending and buying. And let us see, basically, we are trying to create a moat like how Apple is as a company. So over 5 years, 10 years of practice, we have to decide what our moat would be. So more number of equipments, having a complete center, we have to see, how the others are playing the game, and it's a very dynamic market, and a lot of things are changing in the next 5 to 10 years.
Anyone else from the panel if they want to speak upon this?
We learn from examples that we follow, and if we look at, when we begin, probably we have lot more anxiety and lot more, we don't know if we have faith in ourselves that what we will become in the coming years, and at that point probably a loan is a safer option. But once we have built a repute in few years time, when the chances of disheartening the shareholders is less, or we've reached a point of stability where we know that now we are talking about growth and not just the starting point, at that point probably equity makes more sense. Like a good example is probably Dr. Devi Shetty, and if we look at it, when he started probably somewhere in 2000, 2001, it was just him, it was on him. At that point, if probably when he was not Dr. Devi Shetty, I don't know if you'd have had so many investors in him. But if you look at the growth, I think they made their company, Narayan Hridayalaya became private, or like it became an equity market somewhere in 2015. But in that time, if you see the growth from 2000 to 2015, it's not huge. He probably had from 1 to 4. He grew from 1 to 4, so it looks like it's a small growth, but he built himself, he built the name, he built the company, and once everybody knew who he is and what they're investing into, when at that point it came into the market, from 2015 to now it grew to 50. So the percentage just drew manifold. So it's probably a point also that at which point we are going into equity and which point it is still at, we begin with a loan maybe. So it's at...
So thank you, Dr. Ipsita. Anyone from the audience if they want to say anything? So yes, I think we'll close it with this topic, and we have one more discussion which is still there, and we have Dr. De Cruz here, who she'll be speaking about. Thank you, Dr. Vedant and Dr. Ashwini for their talks. She'll be speaking about conferences which should be attended online. We do not have Dr. Amit. I think he's possibly living his topic. He's present somewhere else, and or maybe he's still not come. So we'll have his Dr. De Cruz's talk, and then we'll close it with some discussions on the same. So before...
Yeah, hello everyone. I'm Dr. Aki. So I was supposed to speak against Dr. Amit he was talking on offline conferences, and I'll be talking on online conferences. So COVID-19 has led to a paradigm shift in the practice of medicine, and interest in online webinars and classes grew exponentially mainly during that time. And it was mainly because it gives the audience the luxury to pick and choose which webinars they wish to attend. So now today I'm going to give you 10 reasons to vote for online conferences / webinars. Coming to the cost effectiveness, in an attendee's perspective, there is no need to pay huge registration fees, no need to charge for travel and accommodation. They can attend multiple conferences a year as the budget was not compromised. No dressing up needed, no need to buy expensive suits and saris. Coming to the organizer's perspective, there is no cost for the venue, no catering, no food expenses. Hence, there will not be any mass food poisoning or casualties. Less expenses for audiovisuals, no printing or banner charges. Coming to the second point, that is the participation. The delegate participation has increased fourfold as per the studies when virtual conferences came. There was no limit in the number of audience or hall capacity. Diverse audience from different locations and different countries participated. The number of international speakers also increased twofold. And the main point, women empowerment. two separate studies revealed that online events held during the pandemic resulted in increased participation among the women, both as attendees and as speakers. This is because women are multitaskers, so they were able to manage the household chores as well as they were able to attend the conferences online. Coming to the interaction, there was more robust participation and exchange of ideas, especially because of the chat functionality which is available with Zoom platform. And this also helped to exchange the ideas effortlessly because the webinars allow the participants to interact with the presenters during the live streaming itself. And this was considered to be a better opportunity for introverted people to ask questions or to participate as speakers also. People with stage fright or difficulty in speaking in public can also anonymously use the chat functionality to ask their doubts or give their opinions. Time saving. There was no need of getting leave approval from institutional heads, no loss of pay for you. The talks were all of short duration, hence there was more attention from the attendees, saving the pre-conference and post-conferences travel days, less fatigue, and less chance of communicable diseases. And you can watch any time at your ease, and you can even have a coffee or a snack in between for refreshing your mind. Coming to the residents' perspective, there was a change in the didactic lectures and case presentations to more active video-based classes, and residents even started participating in journal clubs when the online conferences and webinars came. And all the residents learned how to make impressive PowerPoint presentations, and they started utilizing technology. And this online conferences and webinars also help to bridge the teaching gap which is present in various PG institutions in India. And the residents became more aware of the e-learning sources. Thus Gupta et al. Said that because of the role of the webinars, the learning experience of ophthalmology residents have become almost 3/4 of them welcomed this as a very good academic tool. So there was a paradigm shift in the teaching. So as we all know, whenever a new platform comes, there will be many negatives which will be pointed out. But if we keep on looking at the imperfections, we will miss out on the plus points. So the educational goal of this online learning is not to replace the conventional hands-on experiences you get at conferences or the surgical training, but to improve the knowledge and to be updated in the recent advances. Thank you.
Thank you, Dr. Raki. I would want to ask the views of the panel, and we have a couple of minutes, so one pointers from each. Dr. Aarti, from you.
So, since Dr. So since Dr. Amit is not here, let me just say a few points in his favor. I feel that there is a big role of physical conferences. It's not that we have too much of time to see the recordings. I'll ask people sitting over here that how many of us do that. Okay, fine, this was an interesting conference, I was not able to attend, but let me see the recording. It doesn't happen. But when you are in the conference, you are forced to sit here and hear what is happening. Take home points definitely will always remain in your mind because you are physically present over here. The second thing which is against the online thing is if in case you are at home, you'll end up doing a webinar at 8 o'clock, 10 o'clock in the night. And then you may find your partner or children complaining about that you are bringing your work home. So you don't want that to happen. You don't want to compromise your family time. You don't want to mix two of them. So if in case you are gone for AIOC to Kolkata for 5 days, your family has assumed that you are not with them. They are mentally prepared for it. But if in case you keep on doing webinar every week or every third day, over a period of time, you are actually compromising their life as well along with yours.
So I absolutely agree. Both of them have pros and cons, but yes, definitely physical conferences do have an impact on us in terms of the attention spans and also more dedicated and focused learning. So I would be like biased towards physical, but about other things.
I feel it depends again, because if it's a long conference like 4 to 5 days like AIOC, it should probably be physical, because I know doctors in Kolkata who are in clinic and who will be here for their own talks, because it's difficult to prioritize time just for the conference unless you are at the venue. But if it's small ones, it could be hybrid, or even if it's 1 hour one, it could probably help us prevent the commute and, harming the environment commuting just for a 1 hour thing, and it could be online. Thank you.
Dr. Ashish, if you can say something. Or I'll conclude saying that, depending upon the content of what you're presenting, sometimes the content doesn't require any extensive detailing, and that can be done online. But I think physical meets do have a very different impact, and the way you present and what you're presenting, people, if they have better attention span. With this, I think we can close. We thank you, Dr. Raki, for doing it. And I would want all the speakers and the panel people, if you can come up, and we'll take a group photo and we'll call it an end. Thank you so much.
No, we'll just stand through.
We'll just take it here. So we'll request all the speakers also.
आपको डायरेक्ट डाल देता हूँ.
Start smiling now. Wait.